Um, Good afternoon. How are you doing today? Can you hear me loud and clear? Can you hear me clearly? Can you hear me clearly?
Yes.
All right, excellent. I hope your day is going well. So today will be our last session of the free tutorial, and this is our third session. So today, before we go into some questions on hematology, does anyone have any questions that they want to ask or have answered? Question related to the exam preparation, your study technique, or anything related to that, or any other questions related to the exam? All right, go ahead, Hassan. Can you be more specific? Guide on U-word soil. Can you be more specific? Now, what I mean by being more specific, what about going through U-word do you need guide with? What about going through U-word do you need guide with so I can tackle the specific concern you have? If anyone else has questions, you can ask as well. Put it in the chat, or you can use audio or your microphone. So I gave some tips about how to review questions last week for U-word, and I was talking about after doing a block of question, or and you want to review that block, you should prioritize, right? So the first thing is I say you should prioritize, and then you should also time your review, right? Prioritize and time your review. So what I mean by time your review is that you don't, and this doesn't just apply to only U-word, generally speaking, right? This applies to any question bank you're using. So what I mean by time your review is that a lot of people spend a lot of time reviewing questions. Some people review a block maybe all day, and it's very important to time your review and know that you don't have all the time in the world. So you can set like a timer for your review, maybe 3 hours, 4 hours. The idea is to make sure you still have enough time to do more questions instead of spending all the time, right, on reviewing the questions or most of the questions. So that way you can increase your question time. Mind you that when you start going through U-word or any question bank, the review process will be not naturally slow in the beginning, right? So I'm not timing my review in the beginning, right? I don't mind taking as long time as it takes for me to review. So what I can do in the beginning is I can decrease the number of questions I do per day. So instead of doing a 40 question block in the beginning, so you're going through a Qbank for the first time, that is, instead of starting with a 40 question block, you can start with 5 or 10 question blocks, right? And after each 5 or 10, and you're doing this in tutor mode, by the way, not even timed, right? You're doing the block in tutor mode. I will review those 5 or 10 questions for as long as it takes for me to understand what they're saying, what the explanation is. Okay, so I'm not timing my review in the beginning at all. because your goal in the beginning is to understand as much as possible. So in the beginning, you're not timing anything, your review, you're spending time on understanding. You have to ask why and questions and find answers to them. You have to ask how questions. So anything that has to do with mechanisms, you must take the time, either the question explanation, or if you need to read an extra resource to understand what it's saying, you must understand, right? That's the first objective of like a first pass. So in those days, it will take as long as it takes. But the more I do questions, right, the more comfortable I should get. So if I start in the beginning, I'm not timing my blocks, I'm not timing my review, I'm really taking the time to understand, I should be improving. I should understand more. And if I do more questions on the system or the topics I have been doing before or doing on time, I should get better, I should improve. So in that case now, my review should be faster because I should have known more than before and I only need to review less things, right? So my review will be better or will be faster. I can start increasing the number of questions I do, right, per day from maybe 10 untimed. I can increase to 20, 25, 30, and I can start doing timed blocks as well. Once I see that I'm getting a grasp, right, of that concept or topic, all right? And then you add more to that. So when you now start like when you get to a point where you've gone through most of the questions in the Qbank, so I should start doing the maximum number of questions I can do per day. So either during your first pass, you've gone through most of the questions in the Qbank, and we're talking about at least 60% of the questions, or you're doing a second pass of the Qbank. Now, my objective in the second pass or close to the end of the first pass is not just understanding. I want to get more practice. I need to do as many questions as I can per day, right? So this is where you now start timing your review, right? You will start timing your review. You don't want to spend so much time on it. You want to have enough time to do more questions, all right? So I can do a 40 question block timed. That's 1 hour. And then I will set a timer for reviewing that 40 question, maybe 3 hours, 2 hours, 30 minutes, depending on how much I fail or how much of the question I miss, because I need as much time as I can get to do more questions, to get more practice in. So that's when I'll start timing my review. And then you also prioritize your review. So towards the end of your first pass, as well as of course, in the beginning, I'm reviewing everything because I'm focusing on understanding, right, in details. But towards the end of your first pass and the second pass or subsequent passes, you must also prioritize your review because you know some things more than others, right? So the chance that the questions that I get wrong are very clear to me is very high, right? And the chance that the questions I got correctly are clear is high. The ones that I got wrong, the chance that they are not clear, that those are my weak areas, right? The chance is also there. So what you do is you prioritize the wrong questions, right? So towards the end of your first pass or any subsequent pass after the first pass, you want to prioritize your review. If I start reviewing a block, I will review the wrong questions first, right? I'm going to go through the wrong ones first, the ones that I got wrong first. That's where you want to concentrate your energy early on, right? Instead of starting from question 1, 2, 3 in sequence, and before I get to maybe question 20, I'm already tired, or before I get to the end of the block, I'm tired and I'm not focused anymore. And what I want to do is once I start that block, I want to go through the wrong ones first, only the wrong questions first. And then because I want to concentrate my energy on them early on, those will take me more time. I need to clarify what my errors are. So you have to be conscious, find out what your errors are in the wrong questions. Why did you get it wrong? And then you want to read the examiner's explanation, right? Your goal for every review is to make sure that what you're thinking tallies with the examiner. Your goal with every review, every question you review, your thinking must be in line with what the examiner is thinking. Your prediction of the objective of the question must be in line with the objective of the question that you're giving, right? So that is the goal of review. So every time I review a question, my thinking should be closer to the examiner's thinking every time for both the correct and wrong questions, right? So that is the goal. So you have to identify what is the error in your thinking when you're reviewing. Why did I get this question wrong? Do I understand the concept at all? Have I seen it at all? Is it that I changed my mind? I switched to a wrong option? And why did I switch to the wrong option? Why did I change my mind from the correct one? What distracted me in the vignette, right? What did I miss in the question? You have to identify those things. So this is like a detective work. You have to be really intentional about each question. And then, so each time you review a question, you should be closer to what the examiner wants you to think about. You should be closer to what the examiner is thinking about. And that is how you can really maximize, right, your Qbank and your review, and you get better, right, every time, right? You get better every time. So those are the tips that I have really for reviewing, right? Question explanations. Okay. Ogie said that how do I Okay, Aslan has another question. What to do if my scores are not improving after doing first aid and UWard? And what a person should do next? What to do if your scores are not improving after doing first aid and UWard? So that is a very good question. A very good question. The reason for no improvement in score after doing first aid and UWard can be several things. Several things. And your exam is changing, right? The MBME assessment are also changing, but I think one of the most common reasons why there will be no improvement in scores could be silly mistakes, right? Right. One of the most common reasons why there might be no improvement. Actually, when you find out that you actually understand, you can explain things, you understand the why, the what, the how, the details, but you keep making silly mistakes. Silly mistake can be from reading too fast, you're missing important information. Silly mistake can be ignoring important information, right, in the questions. Silly mistake can be clicking the wrong options, overthinking or changing, your mind. So mistakes will contribute, right, to that. If you go through questions and you see the questions and you actually know them, but you find out that you're picking the wrong answer because you made a mistake, you have to slow down more, right? You have to slow down, you have to double check, right? You have to maximize the 90 seconds per question. That can help. You have to maximize the 90 seconds per question to make sure you're not going too fast and you're not missing important things and you're not clicking the wrong option, A instead of B, or something like that. So, and that can be easily fixed, but you really have to be intentional about that, right? Another reason for non-improvement in score will be, I would say, superficial knowledge, where you know the information on the surface, but you don't know it in depth, right? You cannot identify concepts. So, which means that I am doing well. I can even say improvement in my UWord because I'm familiar with the questions. I know the information superficially. But then when you get to an assessment that is testing the concept another way, you cannot apply the concept properly, right? So try to identify concepts in every question, the concept that has been tested, understand the concept, and it can be tested in different ways in different questions, right? But identify the concept, all right? So that may help. Another way could be just understanding as well. The understanding is not in depth. You don't really grasp the information. I would say if that is the case, you can try another resource, right? Try a video resource, a review resource. If you're really struggling to improve your score because you don't really understand what they're saying, maybe the U word expansion is not helpful. First, you're just memorizing and you're not connecting the dots, right? Try review books or videos like Bots and Beyond Kaplan review books. Those can help you, right? Connect the dots and you might be able to see, right, improvement. Finally, a tutor can help as well. Somebody with experience working with you can go through a block of questions with you, maybe for 1 hour, and they can observe how you're going through questions, how you're thinking, how you're picking your answer, and they might be able to tell you, right? Oh, these are the areas that you need to improve on, or these are the tips that can help, right? So a tutor could help as well if you don't see improvement in your score. All right. Oge says, how do I study first aid book effectively? Questions I do when I check up on first aid is just the same. I wish I started using the book earlier during my basic preclinicals. Yeah. So effective use of first aid. First of all, first aid is a review book, right? Not a textbook. And what I mean by that is there are some You can use first aid alone, right? Let me put it that way simply. I can use first aid alone. It's best to use it in combination with other resources, okay? Because there'll be some things like some lines, some information that first aid will not cover. It covers some things like summary in bits, but there are still some missing links, right? There are some things it won't explain in detail, etc. So it should be used as a companion text, right? Companion text with something else. Companion text with UWord, companion text with a review video, right? Um, of some sort, so this can help. But on its own, don't use textbook alone as your only review resource, right? Not going to be a good idea, right? But in combination, it's very good. And I find first aid a very good memory cue as well. So it's a way to know what is super high yield. So you have so many information for your, so much information, right, to know for your exam. Even after I go through my Qbanks and I go through review resources, the information can be so overwhelming, right? So what first aid does is that what for each concept or system or pathway or topic, they give you the concise information of what is high yield, what you will likely see in your exam, what you must know and understand best, right, about the topics. Okay, so it's a good companion resource where even if I've gone through other resources and I have so much knowledge, it will keep you focused on what is very important, what you should know. But please, if you go through any information in first aid and you cannot answer the question why, you still have deficits that may affect you, right, in the exam, all right? So you have to be careful, right, not to over-rely on first aid. You're using it smartly in the sense that don't over-rely on it. Don't use it alone as a review book, and don't memorize blindly, right? Of course, you have to memorize some things, but also keep asking yourself why questions, how questions, and let the Qbank explanation fill in the gap, right, of those why and how and some connections that you may need to know. But those are some tips, right, to keep in mind with first aid. But absolutely very good book, but please don't use it alone, right? Use it in combination with other resources like your Qbank. That's when you can enjoy it, or some review book, right, or review video. That's when you can really enjoy, right, first aid. All right. And if you do UWord, complete 100% and then revise first aid and do all revisions like mailman, it will take about 2 to 3 months during that month. If I do not do question, will it affect my preparation? If you read, okay. Do you 100% and then you revise without doing question? What's your thought on mailman PDFs? Mailman PDFs are also like concise, high yield, right? Information as well. I would not advise using it alone either. I think given the evolution of the exam, where the exam is going much deeper, like they try to go deeper on every subject, pay attention to more details. They try to test mechanisms and understanding more than even facts in most cases. No review book, whether mailman, first aid, etc., should be used alone, right? You can use them as memory cue. So once I studied, I have my knowledge, I have my understanding. When I'm going through those books, be mindful not to be memorizing or over rely on them. You really have to keep asking those questions of why, what, how, trying to connect the dots at every turn you can. They're very good book. They guide you as to what is super high yield, what to focus on, but make sure you're not just memorizing them blindly or reading them passively, right? I would really love to use those books together with things like Qbank. I think that's how you can maximize them, right? And use those books as like your notes. Instead of writing from scratch, you have the books already and you just add in your own information, and then you can use them as memory cues to review, right, over time, okay? But don't use them alone. Don't over rely on them. Keep asking questions, why, what, how, to fill in the gaps, and make sure you understand, right? As much as you can. In terms of taking a break from Qbank to do other review resources for like 2 to 3 months, I don't think it's a very good idea. Especially if I've done UWord 100%, So if I don't do 100%, so one thing is if I'm doing U word more than once, right? Especially if I've done it like at least twice, 2 to 3 times, it will not be a good test of your knowledge and readiness for the exam anymore. It doesn't test your critical thinking anymore, right? So let me start with that. So if I've done U word multiple times, my score is still not improving, I think it's time to try a new Qbank. Change your strategy and try a new Qbank. If you change your strategy and you go back to U word, you're still going to be getting questions correctly out of familiarity, not because you've actually changed your thinking or your approach, or it doesn't challenge your critical thinking, right, as much. So I would advise switch Qbanks, right? Try something else, try Ambos. Everybody says U word is the gold standard. I don't doubt that, but it's not, I see it as one of the gold standard, but not the only gold standard, right? There are other Ambos, Kaplan Qbanks that are comparable, right, to U word in terms of standard. It's the key is how you use the Qbank, most times not the Qbank you use, right? How you use it. So somebody can use U word and not use it well, and they'll still not pass, even if they've done it 5 times, right? And there's somebody that can use Amboss maybe just once or twice and use it properly, like using the tips that I gave you to review and self-evaluating yourself and always asking why and understanding, right? And they'll still do well, all right? So if you use the Qbank multiple times, your score is not improving, you're changing strategy, don't go back to that Qbank again, switch to another one because you're already used to that one. You are familiar with the questions, you're familiar with the answer. It's not going to be testing or challenging your critical thinking anymore. It's time to try new questions, to start challenging your approach from scratch and rebuilding what is weak, all right? So, but don't abandon Qbank completely, right? If I've gone through a Qbank and I want to go to review resources and come back later, I think it's a bad idea. Remember, Qbanks have so many benefits. They're not just testing your knowledge, they're building your exam skills, right? Critical thinking. So the best thing I would say would be to identify the weak areas with the Qbank. So when I do a block, I can go through the block and break down the block and see which areas are weak, which topic, which system. And if I still don't understand the explanation in the Qbank, I can go to my review book and read that specific topic and understand it as much as I can, and then come back to the Qbank and create a block on that topic and practice on it. And you can set a goal. When I'm eating 70% minimum, for instance, on maybe 5 consecutive blocks on that system or topic, I will assume that, okay, now I've improved, then I can move on to the next thing, right? Yeah, so that's what I would say. So use the Qbank to identify which areas are still weak based on the breakdown of the blocks. And then you can, if you keep getting keep getting questions on a particular topic or concept consistently wrong, or you really struggle with a system or a topic, just take that topic to the review book and use the review book, whether Mailman, whichever you can understand well, and connect what the dots you need to connect, and plus the Qbank explanation, and then come back to the Qbank, create a block on that specific topic, practice on it, or create multiple blocks on the system. I can do like maybe 5 to 6 consecutive blocks and see if you're getting averaging at least 70%. Or if you set a target of 80% for yourself, if you're able to get consecutively 80% or 70% on about 5 consecutive blocks on that system or that topic, then you will know that, okay, now I think I got this. And then you know that you can proceed right to the next thing. Okay, so that's what I would advise on that. I hope some of the answers were helpful, gave you some insight. Is there any other questions before we proceed with today's review? How to take notes effectively when doing U word questions. Don't take notes you will not read, right? That's one thing. Don't take notes you will not have time to read later. I think the notes you take, though, however, the notes you take has to be, I would say, personalized, right? Don't write the whole explanation, of course. We don't want to do that. And don't write what you don't understand. So the note should not be about copying the explanation, right? It should be explaining, expressing the information in your own words, in your own understanding, right? So that would be the most effective way. When I go through the explanation for U-word question, or after I've gone through the explanation for U-word question, and I want to summarize the core or important things that I learned from explanation on my notes, I have to summarize in such a way as if I'm explaining to myself or to somebody else, right? In your own words, concise and simple, adding only the details you need, adding only the things that you know that you easily forget, right? For instance, another way to take notes effectively would be to connect your notes with other things, right? So if the concept or the explanation is connecting the question tested to other areas, right? I can, for instance, it's a pericarditis question and is linking it to microbiology of the causative organism. Then I can, in my notes as well, I want to table that connection, right? In a concise way, okay? But your note must be a summary, I would say ideally. It must be in your own words. It must be an expression of your own understanding, right, of the explanation, not a verbatim explanation. I think like some people think that you will see the same words. What some people think is that when you go through your exam, when you go through questions in your exam, like USMLE or NBM exams, and the explanations, that you're gonna see same words on particular things, right? Like for instance, some people think it's better to remember what the name of an enzyme than what it does, for instance. Of course, the name is important as well, but it's not more important than what the enzyme does. So in my notes, it's not just about writing the name. I should be able to explain the function, because in an exam, the examiner might not use the name, but use the description of the enzyme. All right. So those are the kind of things I want you guys to be cautious about, right? Or conscious about. Explanations, understanding why, how, things like that. And your notes should reflect that, explaining things in your own words, not blindly just memorizing or verbatim, right? Copying what you see, right, in the explanation. All right. That's how to effectively take notes. Okay. Writing what you understand in your own words in a concise way. Bootcamp and how can you use it effectively? Bootcamp is good. I've heard testimonials of students that actually struggled a lot to understand U-word, and they use bootcamp, and the way bootcamp breaks down, right? The topics and the words and everything, the way they have arranged their video is really good for a systematic, right? Approach. So bootcamp is very good. If you know you need a review resource, you can use bootcamp. You don't have enough foundation to just dive into questions, right? Because that can be really frustrating. Unless you're very patient with yourself, it can be really frustrating to dive into questions without having the right foundation or some foundation. It can be really discouraging and frustrating. So in that scenario, you want to build some foundation with review resources. Bootcamp is one of those review resources, and they also have their own Qbank as well, which together with the videos, so that's very good. Bots and Beyond also has videos plus quizzes, so that's very good. But I've heard good things about Bootcamp for sure. It does help students that have really low foundation or weak foundation to build, right? Their foundation, right? So it's a very good resource. Yes. To use it effectively, same way your focus will be on understanding. No matter the resource you use, as far as the exam is concerned, it's all about understanding what they're saying, right? So use a resource that you can understand. That's the point. For some students, word explanation is too complex. They don't understand it. It's not that the Qbank is hard, but they don't understand it. So people might find Amboss explanation simpler for them, right? Or concise. And some might find it even more difficult. Do you get it? So you have to, that's why you always do a trial, right? Of any resource you want to use. If there's a short trial or a short subscription to kind of see, it's all about you. It's not about what people say, right? I want you to know that there are so many resources that are comparable to each other, right? If you want to rank best exam resources, please, I don't subscribe to saying UWorld is number 1 and Ambos is number 2 and this one is 3 or 4. I don't really subscribe to that. I believe that a lot of them have the same standard, right, in terms of their effectiveness and preparing you for the exam. So the point still comes down to you. Which resource can I understand, right? So if you go through bootcamp and you understand it, the explanation of the videos and everything they are saying, kudos. Stick to that, right? And your goal will still be understanding. Every video you watch, make sure you can take a concise summary note or say it out or explain it to yourself in simple terms to understand it. You must be able to connect it with familiar concepts that you already know. If I go through a video and I don't understand it, I memorize. I'm saying the same word they are saying. Basically, I'm just memorizing. I can't break it down further. Then it's not for me, right? It's not for me, all right? If I go through a video and I cannot practice, do the quizzes properly and understand the questions there and get a good score, maybe I said 70% for myself, I'm not eating that, then something is missing. It's probably not the best resource for me, right? So whatever resource you are using, what's the best way to use it effectively? Personalize it. Do I understand what you're saying? Can I explain it in my own words, in simpler words, to myself and to other people? Am I able to identify the concept in that video in questions, in quizzes? Am I able to apply the concept consistently to different questions? If you can answer those questions about the resource, that's a good one for you, and you are using it effectively already. If you check, if all those things check out. But if they don't check out, then something is missing, probably not the best resource for you, and or your strategy is wrong, and you have to really reevaluate memorizing versus understanding, right? Yeah. So those are my thoughts on that. In real exam, will they ask same toughness level questions comparable to UWorld? And if we do Ambos, what should be toughness level 3 or 5? They have such thing. What's your thoughts on this? After solving questions, I feel I forget everything. Concept even after understanding. What do you see on this? Yes, yeah, I would say the questions on your exams are comparable to the toughness level of the standard Qbanks, right? Ambos, UWorld, right? Ambos has these difficulty levels 1 to 5. Most of the questions you're going to see in your exam will be falling in the middle of the difficulty level. There will be some 5 AMA questions, which are the really tough ones, the difficult, the maybe experimental questions and co, right? The really tough questions will be 5, but there won't be much. There will be a few, right? A particular fraction or a lower fraction of the exam, and it will be the simple question. The simple questions are questions that just require maybe just recall. If I remember one fact, I can pick an answer. It doesn't require me to go 4 steps, 5 steps of critical thinking, right? So those ones too, they'll be a lower fraction of your exam, but most of the questions will fall within like 2 to 4, right? AMR, right? Levels. Those are questions where you have to know maybe up to 2, 3 facts, or if you're able to go up to 2, 3 steps of reasoning, right, to get to the correct answer. And that's how you should, those are the ones you must master. I would say that if I get all the very, very difficult questions wrong in the exam, I get all the very, very simple questions correctly, plus all the medium, most of the moderate level questions correctly, I will pass. Just to give an idea that those tough ones, there are few fractions, and I won't kill myself on them. Those 4, 5 AMA questions, I won't really kill myself. But you see, the ones that you must know are the 2, 3, 4 AMA questions. Those are the common ones, the ones you see everywhere, see even in real life, right? Clinical practice, and those ones will be the most commonly tested kind of an active recall, right? So you have to use your flashcards, keep information fresh in your brain. That's very important. If you review a question today and you don't see it again for the next 3, 4 days, you are going to forget that concept, most likely. So you have to keep exposing your brain to it at regular interval. One of the things you can do is that before you start studying the following day, review what you did yesterday. right? Before I start studying today, I can review what I did yesterday, or before, as the week goes on, or at the end of every week, I'll review everything I did for that week. So you also have to set up that spaced repetition schedule on your schedule. Maybe every three days, I'll go through my previous notes, go through the previous blocks of questions I did and quickly review, right? The questions I got wrong, right? Every three days or every weekend, I can do that. But you must do that spaced repetition, active recall at regular intervals. Otherwise, you will forget, right? Information. You will forget information. Aisha said, do you think case presentations can help? Is it worth it? I mean, discussing why is it and how is it? It's going to talk long time. Do you think it can help in critical thinking during examination? That's a very good question. Case presentation, discussing with others, right? Why and how? I think the central focus of your exam is mechanism, right? Mechanism. The central focus is mechanism. It is very paramount for you to be able to identify the concept tested by question. Every question you encounter, you should be able to identify the concept that's testing, right? And make sure you understand the concept. So no matter the form the concept is repeated, you can answer it correctly. And how do I understand something very well is by being able to answer questions of why and how. So if you see something, maybe in the answer explanation, and you don't know why it happens, right? Why we give somebody alcohol, use a patient with alcohol use disorder, why do we give them thiamine before giving glucose, for instance? That should be a why question. It's not enough for me to know that I'll give thiamine before glucose. I have to understand why I will do that. What's the connection between them? And you should be able to explain that why to somebody or to your friend, to your discussion group, or to yourself clearly in your own terms. So I think it is worth it. It depends on the amount of time you have. See, let me tell you something. Most of us already know the high yield concepts that you see in your exam. So why are you ignoring them? If I have all the time in the world, if I have a long study time, maybe I'm still in medical school, so I've started preparing early for my exam. Of course, let me do all the case presentation I can do to understand the why, the how, explain them. That's good. But if I have a 3 month window, clearly I cannot do a case presentation on every questions or every topic or concept to explain the why and the how, right? I can't do that because of time, right? But what do? Focus on the super high yield. You know what will likely be tested. How? First aid lists them out. The most likely tested concept are on first aid listed. On your Qbank, questions that you keep seeing 5 times, you see a concept that has 5 questions, 10 questions, you already know it's high yield for it to be tested 10 times in a Qbank, not to talk of your exam. So some people will know lac operon more than coronary artery disease. That's not prioritization. So I should not be able to explain lac operon more than coronary artery disease. I should not be able to explain lac operon more than stable angina and stable angina pathophysiology. Do you get what I'm saying? So you have to prioritize. Those high yield ones must be priority. Lac operon question, maybe you say 1 out of 270 questions in your exam. But for coronary artery disease, you probably see 10 or more. So I can spend time doing the case presentation on those and explain the how and the why. It's going to be worth it. It will take you to a different level and you better engage with the question and the examiner, right? But you can leave those low yield concepts and topics and all that. You may ignore them. If you have more time, you may prioritize them. But I would say that definitely prioritize the high yield, right? Once for that. All right. So that's gonna be that. Okay, Asan says how to use breaks. I think what I tell my students about this is going to be keep going until you get tired in the beginning, right? So when you start the exam, keep going until you get tired. I know a lot of people like to plan, oh, I'll take a break after 2 blocks. I'll take a break after the first block, or I'll just tell them in the beginning at least, keep going until you get tired because you are the strongest, you are the most focused, you are the most concentrated, you are the most determined in the beginning of the exam.
So if I have enough energy to go 3 blocks before fatigue sets in, I'll keep going. If I have enough energy in the beginning to do the first 4 blocks before fatigue sets in, I'll keep going. Because once you have the momentum, right? You go to the first block, you feel good. Momentum, you build the momentum, you go to the second block, you feel good, you're not tired. Keep going. If you take a break, you break the momentum, then you have to come back again and start rebuilding from the third block. So I always tell you in the beginning, keep going until you're tired. Once you feel fatigued, any block you start feeling fatigued and you feel like you start reading questions more than once. So you know that you're fatigued, you're tired, that's when you take a break after that block. And then you come back. Then after that first break, now you can now decide to maybe take a break every block until the end or every 2 blocks, depending on, how you really feel on the exam day. All right. So that's usually my advice for that. Any other questions? All right, keep putting them in the chat as we go on. I will answer. So today, this week in the group, we focused on hematology and oncology, right? Hematology and oncology. That was our focus this week. So I'm going to be going through some hematology and oncology questions with you. And I think this is one of the systems that students struggle with the most, because it has to do with labs, right? A lot of us fear lab questions. We see a lab and we are already, tired, we're already concerned, right? You're already concerned. So we're going to go through some hematology questions and try to see best approach to lab, right? Vignette and how you can maximize as well. For also labs, make sure you know as much lab as you can offhand, right? So that way you're not going to spend too much time going between the question and the labs during your exam. All right. So make sure you know as much as you can offhand. But it's not mandatory. If you can really scroll through the labs quickly, that's good. But you don't want to really you want to save as much time as you can on the question itself or thinking about the question and picking an answer. So if I know some of the common labs offhand, that would be really good as well. That can help. So let's start with this one. So we're going to use the same strategy we used last week. We go through the question and we use the poll, right, to answer the question, and we'll discuss the question together. Okay. So this is our first one. And we have 90 to 120 seconds, right? Yes, cool. All right, these are back to the options.
The poll closes in 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. All right. The most popular answer here is option A. Actually, everybody that answered picked A as the preferred answer. So the question is saying, which of the following is most likely contributing to this patient's gastrointestinal bleeding? What is contributing to the patient's gastrointestinal bleeding? So we have option A, which is a bone brand deficiency, decreased Adams TS13 metalloprotease, decreased synthesis of clotting factors, formation of antiphospholipid antibodies, uremic toxin-induced platelet dysfunction. For these questions, I think it's very important for us to understand the options and also generate. You can also generate your differential diagnosis, right? I think that's for lab questions. I love doing that for lab questions with labs, so that I already have an idea. I can predict what to expect on the labs, and I can easily rule out, right, what doesn't make sense. So for option A, which says acquired von Willebrand factor deficiency, that will be acquired von Willebrand disease, right? What is the differential for option B? What is the differential for option B? What is the differential for option B? Adams TS13 metalloprotease. What condition does that refer to? Right, so that will be TTP, right? TTP, good. Thrombotic, thrombocytopenic purpura, excellent. Option C, decreased hepatic synthesis of clotting factors. That could be anything related to that. We can say liver cirrhosis, vitamin D deficiency, right? Things like that. Formation of antiphospholipid antibodies, antiphospholipid syndrome, right? Which may be related to SLE. Uremic toxin-induced platelet dysfunction, that is a patient with a CKD and also has a platelet dysfunction, right? Because of the elevated BUN. All right. So we have an idea what our differentials are. I should be, from my studies, I can isolate or kind of predict what labs, right, I will expect from each of them, and that can make life easier for you to rule out what doesn't make any sense, okay, or what is wrong. So let's see what we have. We have a 72-year-old man comes to the ED due to increasing dyspnea on exertion. So patient has shortness of breath on exertion. The patient has a history of severe aortic stenosis causing dyspnea, but the symptoms have worsened over the past several weeks. He also notes excessive exercise, fatigue, and several questions of black tarist. So that's the GI bleed. The patient has no history of a blood disorder or conditions, harsh murmur relating to the neck, that is the aortic stenosis murmur. Abdomen is soft and non-tender with no organomegaly, testing of stool, and labs show anemia, microcytic anemia, platelets are fine, PT is fine, but PTT is prolonged. Is it? Is right. PTT is prolonged. Yes. Colonoscopy reveals catarrh bleeding angiodysplasias in the right colon. So, what is contributing to this patient's GI bleeding, right? Okay, very good. So it's all about the labs, really. We can rule out what TTP, right? Thrombotic, thrombocytopenic purpura. Since the platelet is fine, I can rule out TTP, thrombotic thrombocytopenic purpura, because platelet is fine. Hepatic synthesis of clotting factors, I might leave that. Formation of antiphospholipid
There's no history to suggest that recurrent pregnancy loss or DVT, arterial thrombosis, uremic toxin in this platelet dysfunction. It's possible, but there's no evidence of CKD either. All right, A or C. So if the clotting factors are deficient in the liver, it's going to affect both PT and PTT, right? So only PTT is affected here, which means this is affecting only the intrinsic pathway, right? A factor in the intrinsic pathway is deficient. That's why PTT is prolonged, but PT is fine. If there's vitamin K deficiency, that will affect both PT, right, and PTT. So that is out. By default, you're left with A. My question is, what is causing acquired von Willebrand factor deficiency? What in this patient is causing acquired von Willebrand factor deficiency? What is causing acquired von Willebrand factor deficiency in this patient? It is the aortic stenosis, right? If the aortic valve is very narrowed, right? If the aortic valve is very narrowed, and Bolivian factor is squeezing through the narrowed valve or the narrowed orifice, it can get easily fragmented, right? It can get easily fragmented, broken down into pieces, and that will lead to acquired deficiency, right? Why is this patient, so Bolivian factor is important for platelet function, right? Why is PTT prolonged though? If a patient has Bolivian factor deficiency, why is PTT prolonged? Why is PTT prolonged in patient von Willebrand factor deficiency? Because because factor 8 will also be deficient. Yes. So von Willebrand factor protects factor 8. Okay. So if von Willebrand factor is missing, factor 8 will also be what missing. It will be degraded as well, right? And that will lead to prolonged PTT. All right. It will lead to prolonged PTT. Very good. Concomitant factor eight deficiency. So this question is asking you about the option is concomitant factor deficiency. But imagine getting a question where same question like this, and the examiner is asking you what is contributing to the patient's GI bleeding, and you will not see vulnerable factor deficiency in the option, right? You might see factor eight deficiency. You still be correct because of this vulnerable disease. You know that if one factor is missing, factor eight will also be missing. So that factor eight deficiency too can also contribute to bleeding in patients with von Willebrand disease. All right. So you make sure you remember that. This is very good. How can I treat this patient, guys? How can I treat this patient? Same vignette, but it's asking us about treatment. Same vignette, but instead of asking about contributing factor, asking about treatment. What do you think? How can we treat this patient? Okay, so I will give desmopressin. Yeah, so we can replace the valve. Remember, the valve is actually the problem, is the cause. So we can replace the valve, but if it's medical treatment, not surgical, desmopressin will be better than giving factor 8. The reason, even if you give factor 8 and one factor is deficient, right? That factor it will still not be protected and it will still be degraded, right? Yeah, so desmopressin will be better. It will stimulate the endothelial cells to release Volbrand factor and factor 8, right? And that can help the patient, but the valve is what is causing it. It's destroying the factor. If the valve is too narrow, the factor will get destroyed, right? While trying to, if blood is flowing through a narrow valve, cells in the blood or proteins in the blood can get degraded or fragmented, right? Because they are squeezing through a narrowed orifice, all right? Yeah, so that is good. That's good. All right, let's try
this one. Poll is closing in 20 seconds. Begin your answers. And remember, always attempt all questions. Always attempt all questions. That's the only way to grow and learn. You attempt and then you learn from your mistakes, okay? And you adjust. So the poll closes in 5, 4, 3, 2, and 1. And the poll is anonymous, okay? So nobody sees anybody's answers. So don't be afraid. All right. So here we have, I like this question. Which of the following is the most likely cause of this patient's polycythemia, right? Cause of polycythemia. Polycythemia meaning multiple, increased cell count, right? Increased cell count or number of cells in the blood. So we have polycythemia vera, hypoxic erythrocytosis, renal disease, occult neoplasia, relative erythrocytosis. And I hope we all know what these words mean, right? So let's break them down. Polycythemia vera is what? Is a malignancy, right? It's actually a cancer of the blood cells. But in polycythemia vera, all myeloid cell line will be elevated. All myeloid cell line will be elevated. This is very important. So polycythemia is not just red blood cells that will be high. Polycythemia vera. It's not just red cells, platelets, neutrophils, right? Granulocytes, all of them will be high, except the lymphocytes, which have a different, right, cell line. So that's important. In terms of labs, hypoxic erythrocytosis is what? Erythrocytosis, that is the cells that are causing polycythemia are only red blood cells. Erythrocytosis, only red blood cells are high in the blood, not all the cells. Only red blood cells are high. And why are they high? Because it's a compensation for hypoxia. So in my labs, what do I expect to see in the labs for B? I expect to see low oxygen and I will see high red blood cell, but only red blood cells, right? Only red blood cells. Actually, what is high is not even the red blood cell mass. It's more like hemoglobin, right? That's mostly high, right? Hemoglobin, that will be high. as well as, okay, red blood cells will be high, yes. So only red blood cells, right, will be high here, not renal disease. Can renal disease cause hypolycythemia? The only renal disease I think can cause polycythemia is what? Is the paraneoplastic syndrome. Patient has renal cell carcinoma. Remember, renal cell carcinoma can make EPO, right? This can make EPO if it's RCC, and EPO can cause increased red blood cell. Only red blood cell will be high as well, but of course, you expect what? Oxygen to be normal, or even right, and in that case, right? Yeah. So, but you won't see hypoxia, normal oxygen. That would be paraneoplastic. Occult neoplasia too would be like paraneoplastic. But if this option represent, you see represents CKD, like kidney damage, of course, we don't expect polycythemia and kidney damage, right? It will be anemia, right? But if it's a renal cell carcinoma, then it's possible. Relative erythrocytosis is also high red blood cell erythrocytosis, or red blood cell appears high. Okay, let me say appear. Red blood cells appear high, specifically the hematocrit appears high. Why? Relative to what? Relative to plasma. So in relative erythrocytosis, it is not true. This is not true erythrocytosis or polycythemia, right? It is false. If you have cells and water in the blood, right? That's what we have. Blood is made up of water, which is plasma, and it contains cells, which includes red blood cells, right? And we can say if I put all the cells together and I separate them from water, right? We call that hematocrit, right? So why will hematocrit appear higher than usual if the water is low? If water content in the blood is low, right? The red blood cells will appear more concentrated than usual. It's not that their count increases. It's still the normal count or normal mass, but it will appear higher, appear more concentrated. Why? Because there's no water. If I have more water than usual, they're going to become diluted. Does that make sense? So that's what we call relative erythrocytosis, right? So increased red blood cell hematocrit due to low water. It's not because the cells are actually high, it just appears high. It's relative to the water content, right? So these are the options we have, right? So let's go to so this is one of the, this is why I love doing this with lab questions. So we have lab here, right? And I want to apply what we just did here. And you can see that it might be easier for us to get an answer without reading the whole thing. Okay, when you have questions that have labs and all that, you can try this, especially hematology questions. Come up with your differentials and write out what you expect, or think about what you expect the labs will look like for each differential, and then look at the labs and see. It will be easy to kind of pick up what you want, right? Without being confused. So let's start from let's look at only the circled part of the vignette, the one that I highlighted or circled. So on the third day of sterilization, a hematocrit level increases to 50. So hematocrit went up. Okay, hematocrit went up, right? Hematocrit went up. And arterial blood gas analysis shows arterial oxygen partial pressure of PaO2 of 70 millimeter mercury. Is this PaO2 low or normal? PaO2 can be as low as 70. It can be as low as 70 normally. PaO2 can be as low as 70 normally. So it's when the PaO2 is less than 70, or is it less than 75, that will say the patient is hypoxic. But let's highlight that. And then we have tagged red blood cell indicates normal red blood cell mass. This is a isotope CR51 tagged red blood cell, shows normal. This is normal red blood cell mass. My first question is this: based on this isotope, this CR51 tagged red blood cell infusion, right? And basically what this is doing is it wants to see, it's checking, it's a test to check, right? If there's an increase in red blood cell mass in the body or not. My first question is, in this patient, does this patient have polycythemia or not? Does this patient does this patient have polycythemia? Based on that red blood cell mass, that's normal. Is this true polycythemia?
Is this true polycythemia? Based on the normal red blood cell. Okay, the PO2 is low, right? Okay, this is not true polycythemia, right? This is false polycythemia. Polycythemia means increased red blood cell mass or count, right? So they did this test, CR51 tag red blood cell infusion, and it shows that the red blood cell is actually normal. So red blood cells, the number, the mass, the amount of red blood cell in the blood has not changed. The mass, the count hasn't changed. It's still the same. I can rule out polycythemia vera. I can rule out hypoxic. In hypoxic erythrocytosis, it is true polycythemia, right? True polycythemia. You're actually going to see increased red blood cell mass. So this also is out. Even though the oxygen is low, right? The fact that the red blood cell mass is normal, it is not a true hypoxic erythrocytosis. Hypoxia, but it is not, there's no erythrocytosis, there's no true polycythemia, right? So that's out. Renal disease will either cause anemia or also if it's EPO, renal cell carcinoma, the red blood as the best answer. Because although I have evidence that hematocrit is high, which is the blood compared to plasma, right? That's what hematocrit is. So if I have more water in the blood, hematocrit will be diluted. It's going to be dilute. But if I plasma, the cells will be a higher fraction. Does that mean the plasma fraction dropped, has not changed? Okay, so this is what we call relative polycythemia. So what is causing water loss in this patient? Why does this patient have relative polycythemia? What is causing the water loss? Where is all the water? Where's plasma going in this patient? Patient is taking what? Likely taking diuretics, right? Yeah, right. So first edema. Sorry about that, it's disconnected. Right. So the patient is diuretic lost excess water, and that will lead to yeah, more concentrated, right? More concentrated. It's gonna be unlikely heart failure because of these distended negrins and the crackles in the one. Okay. So this is another one.
And let me reshare my screen. Are you sure? Please let me know if you cannot see my screen. I'm already sharing my screen. Let me know if you cannot see the screen. All right, good. So this is another one. Please can you put your answer in the chat until I can get the poll back? Thank you. I will show you all the options for this. This patient is most likely taking which of the following additional medications. This patient is most likely taking which of the following additional medications. We're giving a bunch of options here. So this is a 72-year-old woman brought to the ED because of due to shortness of breath. Due to shortness of breath, pain. She had a similar episode 3 weeks ago and has been treated with warfarin since then. Okay. She had very tachypnea, period pain, and 2 year with warfarin with an aunt. So kind of like adrenaline embolism, right? That's been treated with warfarin. The patient has several other medical conditions, and that's what the examiner wants to figure out which are taking. Examination picture is that blood pressure pulse notable for this. So we have PD of 18, INR of 1.6. Patient INR is subtherapeutic. So when a patient is on warfarin, we want to achieve INR between 2 and 3.6. It's subtherapeutic. What additional medications is the patient taking? My first question is, what concept
I'm very sorry. I'm experiencing some technical issues. Sorry about that. All right. So, I was asking that what concept do you think is being tested here by this question? What concept is this question testing us on? Metabolism of drug. Thank you very much, right? So, warfarin is a very important medication. This is one of the board favorites. I, yeah, right? Favorite. One of the most common ways to test warfarin, right, is a drug P450 is an A, right? We have to know this. This is one of the ways mechanism of action reversing the toxicity P450 and then like that. So this patient is on warfarin and we're not achieving the therapeutic level of warfarin. So what's happening with warfarin? The warfarin levels in the blood is lower than usual, right? Warfarin levels in the blood is lower than usual. So it's interacting with what? With a P450 inducer, right? Very good. It's interacting with a P450 inducer, a drug that will induce P450 and increase the metabolism, right, of warfarin. So if we look at our options, that leads us to what? Which of the options is a P450 inducer? Is going to be phenytoin, right? Phenytoin is a P450 inducer. Messaging inhibitor, diazepam, no effect, and says in the metasensitive likely inhibitor, metronidazole inhibitor. Opioids, I don't think they have an effect inducer. And if it's combined with warfarin, the levels of warfarin will go down faster than usual, and the patient will not achieve, right, the therapeutic levels of the drug. On the other hand, if warfarin is combined with a P450 inhibitor, it will accumulate. Patient INR will be higher than 3, and the patient can bleed easily in that case. All right. Any question on this? Who can tell us how warfarin can interact with broad spectrum antibiotics? Who can tell us the connection, or who knows the connection between warfarin and broad spectrum antibiotics? Yeah, Aisha knows. Aisha, you can unmute and tell us, if you're not shy, or you can type it, that's fine. And I want somebody else to tell us, how do we reverse warfarin toxicity? How do we reverse warfarin toxicity in a patient that is actively bleeding? How do we reverse warfarin toxicity in a patient that is actively bleeding? Okay, Aisha says gut bacteria. That is very good. That is very good. Gut bacteria. So remember that vitamin K is synthesized mostly by what? By the gut flora, right? Gut flora makes vitamin K. Okay. So if a patient is on broad spectrum antibiotics, maybe for sepsis, and that puts them at risk for what? For warfarin toxicity, because warfarin competes with vitamin K. So imagine already given the therapeutic dose of warfarin, within 2 to 3 INR started taking piperacillin, back the INR will actually increase, right? And that patient can bleed, all right? Can bleed easily. So that's the relationship between warfarin and antibiotics, okay? Very important, high yield for the bot. In terms of reversing warfarin toxicity, if a patient is actively bleeding, yes. So we want to give FFP, right? Fresh frozen from. So if a patient has warfarin toxicity and they're actively bleeding, you don't have time. Vitamin K will take time to kick in, right? If I give vitamin K, I dose vitamin K alone, it's going to take time to kick in, right? So ideally in that scenario, since they actively bleed an emergency, you want to quickly replace the factors and you can give fresh frozen plasma, right? But if the patient is not bleeding, actively bleeding, after stopping warfarin, I can give high dose vitamin K, right, to reverse toxicity, right? But if the patient is actively bleeding, you give fresh frozen plasma, all right? So phenytoin would be the best answer in this case. Thank you. All right, let's try this. I hope my poll is back. Okay, good. So let's try this and use the poll. 120 seconds. Oh, my poll is closing in 5, 4, 3, 2, 1. Very good. So C is the most popular. 50% of us went with C. Of those that inside went with C. And then we have A and we have E. 2 persons went with E, and this is most likely responsible for secreting this hormone. If time was on our side, I would have asked each anyone that picked each option to tell us why. So yeah, their thought. Which reference is most likely responsible for secreting? Most likely for secreting this hormone. What hormone? Right? The question we need to ask is what hormone? What we need to find is what hormone. If I know what the hormone is, I will figure out the cell responsible for secreting the hormone. Right? So the question says, so the hormone, I remember what I told you, whenever the question uses these whatever is they're referring to will likely be mentioned before the question, just before the question. So let me see if I can figure out what the hormone is without reading, right? The whole vignette. So here we have, she's reassured that iron homeostasis is closely regulated. As the body's iron stores increase, a hormone is released and functions in reducing the amount of dietary iron absorbed by the intestine. So the hormone the examiner is referring to is the hormone that regulates iron stores in the body, and the hormone is released. Stimulus for the hormone is excess iron, right? When iron stores are full, the hormone is released and it blocks the absorption of more iron. So it's a regulatory. Okay, can anyone tell us what this hormone is? From that information, what is the hormone here? What is the hormone here? What is the hormone referred to here? A hormone that will be released and blocks the release of the absorption of iron from the intestine. When iron is high, the hormone will block the absorption of further iron from the intestine. I think this hormone is hepcidin. I think this hormone is hepcidin, right? I think this hormone is hepcidin. Excellent, right? Hepcidin. So this hepcidin, right? So in response to iron stores, when iron stores are increased, will suppress like iron transporters in the small intestine, like ferroportin, and blocks for the iron release. All right. So secrete hepcidin, guys. Which cells secrete hepcidin? Which cells secrete hepcidin? That's to be the most popular answer in our poll, which will be the liver, right? So liver parenchymal cells secrete hepcidin, right? So from the name hepcidin, hepatic, right, is going to be the liver, all right? That secretes hepcidin. Can someone tell us the name of the gene or protein that actually senses, the name of the gene or protein in hepatocyte or receptor that senses iron levels hidden when iron is high? Can someone tell us the name of the receptor or the protein that senses iron in hepatocytes and then tells the hepatocyte to release hepcidin when iron is high? It's going to be HFE, right? Thank you. HFE, right? So HFE is the receptor, is the sensor, right? HFE is the sensor. And HFE, in response to high, HFE is going to sense, it senses iron levels, right? So when iron is high in the body or in the blood or is sufficient, HFE will sense it and then tell the hepatocyte, this is also on the hepatocyte, tell the hepatocyte to release hepcidin, right? And hepcidin will go and block ferroportin. So ferroportin is an iron transporter. It's going to block ferroportin and other iron transporters in the small intestine and prevent the absorption, block the absorption of iron, right, in food, block the absorption of dietary iron in food. Okay, so that is the connection. In hemochromatosis, what is mutated? In primary hemochromatosis, what is mutated? In primary hemochromatosis, what is mutated? HFE, very good. So HFE is mutated, which means that the hepatocytes cannot sense iron, and the body will keep absorbing iron, and that will lead to iron overload, right? It's gonna lead to iron overload. Excellent, excellent. Which hormone or which protein or component this diagram is going to play a role in the pathogenesis of anemia of chronic disease. Role in the pathogenesis of anemia of chronic disease. Which component on the HFE, hepcidin, or ferroportin that will play a role in anemia of chronic disease or be responsible for anemia of chronic disease? It's going to be anemia of chronic disease. Chronic inflammation will do what? Chronic inflammation is going to interleukin 6 rather will be high, right? Interleukin 6 will tell the liver to make acute phase reactant. Hepcidin is one of the acute phase reactants. So interleukin 6 will be high and tell the liver to make hepcidin and other acute phase reactants. Others include ferritin and co, right? The acute phase reactant. So hepcidin is one of them. And hepcidin is going to what? Block ferroportin, which is not only on small intestinal cells, it's also on macrophages, right? In the bone marrow. So this will trap. Macrophages cannot release iron, right? For red blood cells to use. So it's going to trap iron in the cells and lead to what? Anemia of chronic disease, all right? Okay, are we making those connections, right? This is how you should be studying. Okay, connection. If you study a pathway, make sure you connect every disease that is connected to that pathway, like we did here. We started with just understanding the normal regulation of iron, and then I'm connecting the pathology, hemochromatosis, right? HFE mutation. I'm connecting anemia of chronic disease, right? Related to interleukin 6 elevation in patients with chronic inflammation, right? So make sure you Oge says she doesn't understand the last question we explained, so I'm going to do that again. So remember that vitamin K, the major source of vitamin K is the gut flora. The major source of vitamin K is the gut flora. And so gut flora makes vitamin K, right? Gut flora makes vitamin K. And vitamin K is responsible for coagulation factors and everything like that. So what does what we call epoxide reductase? And this is the enzyme that converts vitamin K to the active form, active vitamin K, and then we'll use that to make coagulation factors 2, 7, 9, 10 CS, right? 2, 7, 9, 10, and the anticoagulant C and S. Active K. So this epoxide reductase is the target of warfarin. Warfarin is a competitive antagonist of vitamin K because they look the same. Warfarin looks like vitamin K. It will compete with vitamin K for active site on epoxide reductase and block the activation of vitamin K, right? So warfarin is going to compete with vitamin K and compete and right? If it's a competitive antagonist, their action is higher, their effect is higher if the vitamin K is I apologize. So let's say patient is on, like you said, got flora, vitamin K, epoxide reductase, and we have our active vitamin K, you have your factors. So let's say patient is on warfarin. Initially, we've achieved the target INR, which is 2 to 3 on warfarin. If the patient start taking broad spectrum antibiotics, right? Broad spectrum antibiotics, the gut flora will be destroyed by that. So patient is taking broad spectrum antibiotics for sepsis, for instance, or another thing, pneumonia, and infection. The gut flora will be destroyed by antibiotics, right? Some of the gut flora will be destroyed, and if they're destroyed, what happens to vitamin K levels in the patient? It's going to go down. If it goes competition, right? If vitamin warfarin, right, arbitrary effect of warfarin on goodness. Good, good, good. All right. So even without warfarin, right? Giving breast milk antibiotics can actually cause bleeding because of that mechanism. It could decrease gut flora, cause vitamin K deficiency, and the patient can bleed easily. All right. Sorry about the connections. Okay, let's try this. Ten seconds to go. Your pool is closing in 5, 4, 3, 2, and 1. Right. So usually following correction factors is most likely to be abnormal in this patient. Usually following factors is most likely to be abnormal in this patient. So we have factor 5, factor 7, 8, 12, and fibrinogen. Right, to be abnormal. As usual, like I said before, one of the tips for these questions, this like kind of question, will show you where you know that you likely depend on the lab. You can already glance, you can see that there's a lab, some labs given to you. You likely need the labs to figure it out, right? Or narrow it down. Is to one of the key things is to kind of predict what you expect the labs to be. So we have two labs here. And the labs we're giving is PT and PTT, right? So for factor 5, PT is going to be so factor 5 is one of the common factor, right? If I'm not mistaken, factor 5 is a common factor. So what will happen to PT and PTT? Let's even do that together. What do you expect to happen to PT and PTT in factor 5 deficiency? Which one will be high? Which one will remain normal? Will both of them be high? Or they will both be normal? What do you think? Factor 5 deficiency. So both be high because of where factor 5 is, right? So factor 5 is one of the common factors in the coagulation cascade. So I have my extrinsic pathway, which starts from factor 7 and goes all the way to factor 1. And PT or INR measures the extrinsic pathway. So if I activate factor 7, the time it takes to go from 7 to 1, which is fibrinogen, right? That is PT or INR, right? PT or INR. But then, for if I want to measure the time it takes to go from factor 12 to fibrinogen or fibrin for factor 1, that's going to be my PTT, right? Lab test. That'll be my PTT. So in this case, if a patient has factor 5 deficiency, if patient has factor 5 deficiency or abnormality, then what will happen? The PT is or INR is going to be high. Just look at factor 5 here. So it's whether I'm measuring PT or PPT, right? Both of them will be high. If factor 5 is deficient, it's going to affect both of them. So I expect both to be high, right? What about factor 7? If there's factor 7 deficiency, which time will be high if there is factor 7 deficiency? Factor 7 deficiency PT, right, is going to be high. As you can see there, 7 is only confined to the extrinsic pathway, right? So in 7 deficiency, PT will be high, but PTT will be normal. Factor 8 deficiency is going to affect only PTT, right? PTT will be high, but PT will be normal because 8 is part of the intrinsic. It's unique to only intrinsic pathway. So it will affect only PTT, right? It will not affect PT or INR. Factor 12, also only PTT. And we expect PT to be normal. And fibrinogen, if fibrinogen is deficient, both of them can also be affected, right? Fibrinogen is deficient because it's one is part of the common pathway, right? So it will affect both labs, all right? So the only one, since an examiner cannot give you two correct answers, right? Based on the concept that an examiner or principle that an examiner cannot give you two correct answers, the only one that is unique, that doesn't have a companion, will be factor 7 deficiency. So even before I read the labs, 7 will likely, because option A and option E will have the same labs. So I can give you two correct answers, right? An examiner can give you two correct answers. On option C and D, they have the same labs. So you can be given two correct answers. So only
B stands out. And if you look at the labs you're given, we already predicted what we expect to see in B, and we can say that the PT here is high and the PTT is normal. So B would be the best. Hassan asked the question before about if how can I review in depth, right? When I have to time my review. Remember, your timing of review, like I mentioned before, is only when you're doing a second pass or when you're close to the end of your first pass. It's not from the beginning. You have not gone through a Qbank before in my life. I'm just starting you what today. You are not doing timed review. You will take as much time as it takes for you to understand the concept. And that's why you've been making all those connections you have to make from the explanation, from your U word, and from your first aid. I can go to first aid. If I have the soft copy of first aid, when I'm doing my in-depth reviews, I can use the search function of the soft copy of first aid to search the concept, maybe search warfarin or search vitamin K or search like we did for Epsidin and HFE. I can search Epsidin and see where else it appears, right, in the book. And that might help you connect multiple systems, right, together at the same time. All right. So but your in-depth review will be in your first pass when you're going through the Qbank for the first time. If you've already gone through the Qbank and you're doing your second pass, your in-depth review can be hastened by using first aid, but using the search function of first aid. So I can pick a keyword, search first aid, and you see everywhere it appears on first aid, and that will help you integrate, right, multiple systems or multiple locations where that concept applies. All right. Yeah, let's try this. Which of the following is the most likely cause of this patient's anemia? Cause of anemia. So I'll show you the question and then I'll scroll down back to the options. Let me show you the options. Our poll closes in 20 seconds. Poll closes in 5, 4, 3, 2, and 1.
So we have mixture of answers between B, C, and D. All right. Okay, this is a good one. Which of the following is the most likely cause of these patients' anemia? EPO deficiency, hemolytic anemia, iron deficiency, thrombotic microangiopathy, vitamin B12 deficiency. So this 32-year-old woman comes to the office due to worsening fatigue and exercise intolerance. So those are features of anemia. Mucosal pallor, anemia. Hemoglobin is low, confirms anemia. Peripheral blood smear is shown in the image below. What is the cause? Okay. What do we see on peripheral blood smear? So actually, peripheral blood smear should be the key here. Maybe lack of history of, no, that doesn't matter. But the fact that she's otherwise healthy, not an abnormality. Okay. So what do you see on peripheral blood smear? Is there any abnormal cell there? Does anything jump out to us? In this peripheral blood smear, I have two types of red blood cells. The ones that are deeply red and small, and these ones that are not very red, they're like pinkish, and even look at this one, they're even bluish. This one, this one. And then you have these ones, right, which are red and smaller. What do you think process happening? These ones, what are they? Cytoplasm is not red, it's bluish. One of them still has nucleus. So these are going to be reticulocytes, right? So reticulocytes are those red blood cells that have not fully matured yet, meaning that they look bigger because they still contain organelles, right? They've not extruded all the organelles that they carry, including the nucleus. So they are going to look bigger. The cytoplasm look pinkish instead of red, or it's like light blue or so, mixture of violet between red and blue, because they still contain organelles. So they don't contain, if they contain only hemoglobin, they're gonna be red, completely red, right? But because there's no hemoglobin there yet, it's not only hemoglobin that is there, they still have some organelles there, ribosomes and all that. So that's what's give them that color compared to these ones, the other ones that we have there, the smaller ones. And then some of them still has their nuclei, right? So this will be reticulocytes. So given that new information, which anemia does this patient have? Because of anemia, we'll have a lot of reticulocytes in the blood. What cause of anemia will lead to reticulocytosis? It has to be hemolytic anemia, right? So reticulocytes represent the bone marrow's attempt to compensate for peripheral loss of red blood cells. So during hemolytic anemia, the bone marrow will be pushing out more reticulocytes to compensate, right, for the loss of peripheral red blood cells through hemolysis. So that's why B will be the best. In iron deficiency anemia, expect to see red blood cells with increased central pallor. So you have red blood cells that will have wider central pallor, which is hypochromic, right? Or hypochromia. Thrombotic microangiopathy, I will see schistocytes, right? Schistocytes or element cells, fragmented red blood cells, we don't have that here. In B12, we see megaloblasts, which are very large red blood cells, mostly in the bone marrow, not even the periphery. And then erythropoietin deficiency, we're still going to see nomocytic anemia, but you won't see reticulocytes, right? Because there will be no erythropoietin to stimulate
reticulocyte synthesis by the bone marrow. So reticulocytes will be low actually or absent in the peripheral blood. So B here will be the best. Reticulocytic or reticulocytic anemia will be hemolytic anemia. All right, guys, thank you so much for your patience. I appreciate it. I am right. So this will be our last session. I'm really, really sad because of that. I really enjoyed this time with all of you. But we're still gonna be continuing these sessions with the paid community, okay? So we'll be sending out some emails after this class, and you can check it out on how to sign up for the paid community, which is just $120 for 3 months. And that promo we end, right? Tonight. After tonight, it's going to be $150, right? Dollars for the whole 3 months. So, but we're going to be doing the same thing. We are coming up with figuring out new ideas to keep the community more engaging and keep you more engaged and challenge you in the WhatsApp group. And then our sessions, weekly sessions like this, we continue to keep giving you tips, answering your questions, and giving you the push, right? And guidance that you need. And we have other services as well, like one-on-one tutorials, and we have some self-paced courses that you can benefit from. So whichever one you think will benefit you the most, you can reach out to us, and we'll be happy to also talk to you for 30 minutes without charge to figure out how best to maximize your preparation for the exam. Thank you very much for your patience. I will see you guys around, okay? Have a wonderful day.